Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 406 of our pharmacotherapy series, which majors in headache. This clinical case concerns patient LPO from part 404 and 405 of this pharmacotherapy series. LPO has noted that for some migraine episodes, nausea and vomiting has been severe, and asks about the use of dihydroergotamine and antiemetics. My first question to you reads: what is the role of ergot alkaloids and/or antiemetics in migraine management? Let's briefly look at ergot alkaloids. Relative to triptans, ergot alkaloids function as receptor agonists with strong affinity at 5-HT1A, 5-HT1B, and 5-HT1D. In addition, these agents express activity at 5-HT1F, as well as alpha and dopaminergic receptors. This pharmacologic profile differs from that of the triptans because the latter exhibit no affinity for dopaminergic or alpha receptors. Actions of ergot alkaloids are multifaceted, blocking neuropeptide release, stimulating the ventro-postero-medial thalamus, and blocking transmission of afferent signals in trigeminal circuit. Although ergot alkaloids have demonstrated benefit in managing migraine, the more targeted pharmacologic profile of the triptans has gained preference. Intranasal administration of dihydroergotamine has yielded significant improvements in both pain reduction and functional status in comparison with placebo. A 2 mg dihydroergotamine dose achieved headache resolution at 4 hours post-administration for 70% of subjects, compared with 28% in the placebo group. This level of efficacy at the 4-hour time point for dihydroergotamine has been further substantiated in comparison with sumatriptan. Subcutaneous administration of 1 mg dihydroergotamine or 6 mg sumatriptan resulted in comparable headache resolution. Functional capacity at 1 hour, as well as the proportion of patients achieving pain relief at 2 hours post-administration, favored sumatriptan. Adverse outcomes of nausea, vomiting, and injection site pain were more prominent for those administering dihydroergotamine, whereas incidence of chest pain was more common in the sumatriptan-treated group. Orally inhaled dihydroergotamine represents a newer, non-invasive delivery system, marketed as Tempo Inhaler, by MAP Pharmaceuticals. Superiority to placebo has been demonstrated in the Freedom 301 study across endpoints of pain relief and freedom from auditory sensitivity, light sensitivity, and nausea. Associated adverse effects included product taste and nausea, 6% and 4%, respectively. This delivery system is not yet commercially available. Peripheral and cerebrovascular disease, renal and hepatic disease, sepsis, and cardiac disease qualify as contraindications to the use of ergot alkaloids. Further, with the potential to induce uterine contraction and distribute into breast milk, use is contraindicated during pregnancy and lactation. In patients with a history of hypertension, it is important to determine whether blood pressure is appropriately controlled before considering the use of these agents in migraine due to the potential for arterial constriction peripherally. Compared with ergotamine, dihydroergotamine exerts a more variable effect on blood pressure. We will now look at its adverse effects. Nausea is the most prominent adverse outcome with ergot alkaloids. The effect is dose-related and is linked with 5-HT2 and 5-HT3 receptor activation. Intranasal dihydroergotamine and orally inhaled dihydroergotamine have been associated with prolonged nasal congestion and altered taste. Parenteral administration has been associated with lightheadedness and leg cramping. We will now briefly look at antiemetics. In most patients, Triptan agents provide effective relief of migraine-associated nausea. Therefore, specific antiemetic therapy usually is not required. However, as mentioned previously, persistent nausea is more common in patients who use ergotamine for acute migraine therapy. In these patients, and in Triptan-treated patients who experience incomplete nausea relief, adjunctive antiemetic therapy should be considered. Results from a more recent comparative trial, prochlorperazine IV dosed at 10 mg versus metoclopramide IV dosed at 20 mg, found similar efficacy in managing nausea. Efficacy of metoclopramide has been demonstrated at the lower end of the dosing scale, that is 10 mg, but higher doses, that is 20 to 40 mg, were not associated with improved outcomes. My next question to you reads: in addition to triptans and ergot derivatives, what other abortive agents are available for outpatient treatment of acute migraine? We will now look at non-steroidal anti-inflammatory drugs and combination analgesics. Many non-steroidal anti-inflammatory drugs and combination analgesics containing caffeine have been shown to be effective for the acute treatment of migraine headache. Significant clinical benefit in double-blind, placebo-controlled trials has been shown for aspirin, ibuprofen, naproxen sodium, and combination analgesics containing acetaminophen, aspirin, and caffeine. Ketoprofen doses of 75 or 150 mg have demonstrated efficacy relative to placebo in reducing migraine severity. LPO reports that her migraines have been successfully managed with naratriptan 2.5 to 5 mg per episode, with most episodes resolving with the lower dose. Naratriptan was selected on the basis of a lower likelihood of recurrence. LPO has been experiencing a severe migraine for the past few days and has been unsuccessful in treating the episode with naratriptan. She has now sought treatment at a nearby hospital and has been diagnosed with status migrainosus. So my next question to you reads: what is the most appropriate approach to managing status migrainosus in LPO? Let's begin with intractable migraine. Status migrainosus, or intractable migraine, is characterized by an extended duration of headache, exceeding 72 hours. The typical management strategy usually requires hydration and parenteral therapy with ergot derivatives, sumatriptan, or opioid analgesics. We will now look at dihydroergotamine. Dihydroergotamine has demonstrated efficacy in treating intractable migraine by either intermittent or continuous administration. The successful resolution of symptoms by dihydroergotamine avoids the need for administration of corticosteroids and opioids for the same purpose. Adjunctive antiemetics should be administered for nausea. And now we will look at sumatriptan. Sumatriptan 6 mg subcutaneously is also effective for the treatment of established migraine. If the first injection does not provide relief at 1 hour, a second injection may be administered. Sumatriptan should not be administered within 24 hours of ergot alkaloids, because of the potential for prolonged vasospastic reactions. Regarding prochlorperazine. Prochlorperazine has established efficacy in managing migraine-related nausea, with intravenous administration being effective during intractable migraine. In randomized, controlled trials, prochlorperazine 10 mg IV was more effective than placebo, IV metoclopramide, IV ketorolac, and IV valproate for the treatment of acute migraine in the emergency department. We will now look at corticosteroids. Parenteral dexamethasone may be administered in cases of intractable migraine. Among a subset of patients experiencing migraine symptoms beyond 72 hours, a greater percentage of patients achieved pain-free status following parenteral dexamethasone administration, relative to placebo. Further, lower headache recurrence has been observed in patients receiving dexamethasone after standard abortive treatment. LPO may be treated with dihydroergotamine, sumatriptan, prochlorperazine, or metoclopramide due to demonstrated efficacy and tolerability in comparison with other treatment options. During a return visit to her primary care physician, LPO has reported that most migraine episodes have been successfully managed with naratriptan. Although effective, she expresses concern related to episode frequency, noting that in some instances, she is using naratriptan 3 times weekly. Her primary care physician is considering prophylactic management and wants to prescribe propranolol. So my question to me reads: is propranolol an appropriate option for LPO? We will briefly discuss prophylactic therapy. We will focus on the criteria for use. The relevance for initiating prophylactic therapy for migraine is not simply defined by one common feature among patients. Rather, the impact of migraine for an individual patient needs to be assessed. Estimates pertaining to prevalence suggest that only a small percentage, around 5%, receive prophylactic management. Targeted outcomes for prophylactic therapy includes a reduction in both migraine frequency and severity, enhancing response to acute management strategies, and a general improvement in daily function. As previous criteria have addressed the frequency of migraine episodes, 2 or more episodes monthly. As a principal consideration, further guidance on suitability for such treatment should also address disability associated with the episodes, track record of failure with acute treatments or the overuse of acute treatments, adverse effects precipitated by acute treatments, or a more pathologically complex migraine, e.g., basilar or hemiplegic episodes, prolonged auras. Optimizing prophylactic treatment may likely require a 2 to 3 month window. This becomes an important consideration to convey to patients with a focus on maintaining adherence. Medications utilized in prophylactic migraine management generally fall into the categories of antihypertensives, antidepressants, or anticonvulsants. A fourth category comprised of non-prescription treatments is considered as well. The evaluation of evidence associated with prophylactic treatments is often challenging due to the lack of studies with comparisons between agents or with crossover design. An evidence-based guideline for prophylactic treatment of migraine has been created by the U.S. Headache Consortium, published through the American Academy of Neurology. Further evidence has been provided via a combined panel of the American Academy of Neurology and the American Headache Society. Migraine prophylaxis is an area for which the off-label use of medications is a particularly common practical consideration. Only a select number of agents have been approved by the Food and Drug Administration (FDA) for migraine prophylaxis in the U.S., including propranolol, timolol, topiramate, valproic acid or divalproex sodium, and botulinum toxin A, marketed as ONA botulinum toxin A. The approval of botulinum toxin is within the context of treating chronic migraine. Although triptans are not FDA approved for migraine prophylaxis, select agents, frovatriptan, naratriptan, and zomitriptan, are considered off-label for migraine prophylaxis during menstruation. We will now look at propranolol. Evidence supports propranolol's safety and efficacy in migraine prophylaxis. Various mechanisms for efficacy may be considered, including the modulation of central catecholamines and interaction with serotonin receptors. Propranolol has also demonstrated a suppressive effect on cortical spreading depression in animal models. In a small study of migraine patients, propranolol has decreased cerebrovascular reactivity, mediated by action on vascular tone. For LPO, the prescribing of propranolol for migraine prophylaxis could be considered, as there are no contraindications within her profile that would prevent use. A limiting variable to continued use may be the adverse effect profile, including lethargy, fatigue, and sleep disruption. As an alternative to propranolol, metoprolol could be considered similarly appropriate for LPO. Comparisons with aspirin or propranolol suggest that metoprolol would be appropriately effective. Metoprolol has been further compared with nebivolol. While similarly effective in prophylactic migraine management, better tolerability and ease of titration were associated with nebivolol. We will now discuss dosing of propranolol. Initial dosing for propranolol for prophylaxis of migraine headaches is 20 mg by mouth 2 or 3 times a day, with gradual titration, that is at weekly intervals, according to patient tolerability to 80 to 160 mg per day in 2 to 4 divided doses. Once the daily dosage of propranolol required to control headaches is established, patient adherence may be improved by changing to a long-acting oral dosage form, e.g., Inderal LA. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 407.